Pam, thanks for joining us today. I know there are literally thousands of different rare diseases, and I understand that people living with rare diseases often have, if they're fortunate, they have treatment options, FDA approved treatment options, but many still don't have FDA approved treatment options. So I wondered how would adopting most favored nation or MFN and foreign reference pricing affect people's access to those treatment options for rare diseases.
Well, thank you, Candace, for having me. You're very correct. There's over 10,000 rare diseases that we know about that exist today. And despite the incredible progress that we made scientifically, medically, in the development of treatments ever since the Orphan Drug Act was passed over 40 years ago, we still have a long way to go. We, the progression and the evolution of science and discovery, medical discoveries have outpaced the development of therapies, leaving us with still 95% of those 10,000 rare diseases without a treatment. So the majority of our community is looking for treatments to address their symptoms, improve their quality of life, and ultimately cure their conditions so they can live healthy, prosperous lives. So, we at NORD know that when you're dealing with small patient populations, it's often difficult to establish the incentives to study and treat them, develop commercial products for them, which is really the underpinnings of the Orphan Drug Act and why NORD's founders found it so important to bring forth that kind of legislation. We still have a ways to go, and we do applaud efforts to ensure that patients can access these treatments, and that therefore the cost to some degree enter the picture. But we are concerned with the MFN framework that is being discussed and considered today because for many reasons, but importing um, um, foreign kind of rationing rules, if you will, and looking at a framework that is applied to a different country with a different set of rules, a different healthcare system, doesn't necessarily apply as well in the United States. And we want to make sure that it doesn't block innovation and access to life-saving treatments for rare diseases.
You raise a lot of great points, and I think the simple explanation or desire behind MFN is having European or other country prices, but the assumption is that we still have U.S. innovation. And you also mentioned how different countries really have different systems. Many of the countries referenced in the MFN proposal for comparison of prices use a QALY or quality adjusted life year based measures to set their prices. And QALYs are pretty controversial and have been really widely criticized as discriminatory against people with disabilities and chronic illnesses. And I understand, in fact, that federal law prohibits Medicare from relying on QALYs in reimbursement. So, what would it mean for people with rare diseases in particular if these standards were imported into US policy through MFN?
Um, it's a very good question, very good point. These qualities are quality adjusted life years. It's harder to say in the long version of the name. As you said, they measure the value by estimating how much a treatment improves the quality of life or the quantity of life for a patient. And by design, people with rare diseases or disabilities often start at a lower baseline health status, which means therapies for them are scored as providing less value, even if the drug is life-saving. So, that's kind of a fundamental premise that is a challenge for rare diseases. And countries that use quality thresholds routinely deny coverage for rare disease therapies, arguing that they're not cost effective. So that is counter to what we want to have accomplished for rare disease patients living in the United States. Um, And we're concerned that U.S. patients may face similar exclusions, really contradicting what we're trying to do, as you said earlier, with our existing U.S. protections against discriminatory coverage decisions. So that's a big challenge that we're concerned about that application here in the United States.
You also spoke about the challenges in rare disease innovation, and rare disease therapies often involve truly groundbreaking science. There's a lot of genetics associated with many rare diseases, and that requires a high upfront investment and the development costs. You spoke to the small populations as well, and that means clinical trials that can be quite dispersed. So, how could MFN's reliance on foreign pricing benchmarks undermine those incentives for investment and innovation in treatments for rare diseases?
Yes, this is one of the areas that we're very concerned about, and I think it really speaks to NORD's origins and underpinnings with the establishment of the Orphan Drug Act, because it was all about promoting innovation and creating this pathway for the development of treatments. And with rare disease therapies, including many cell and gene therapies, they often require years of research, and the clinical trials are small, sometimes very challenging to develop and implement. And they often require specialized manufacturing. So these costs are spread over very small patient populations, making sustainable pricing essential for those who are developing these therapies to recoup their investment and fund future research. So, this kind of foreign price benchmark really discourages R&D, or we're concerned that it can conceivably do that. And um, that has to be examined very carefully. It could also impact future pipelines. The consequences of not pursuing new treatments is a real thing, in addition to the potential return on investment. And Patients could even lose those future cures before they even exist. It's a real concern. And reducing global access to innovation. As you know, rare diseases know no boundaries. They exist across the globe, and because we're dealing with small patient populations, it's even more essential that we work across the globe in connecting and finding patients and engaging the community, and strengthening the capacity of the community to engage and research clinical trials and access to therapy. So historically, the U.S. has been the first to launch market. It's been for many rare disease drugs, a preponderance of them. So giving patients faster access to innovation in the United States, and MFN could reverse that, leading to delays or companies avoiding U.S. launches altogether.
Let's talk a little bit more about that access because it is important, and maybe for people living with rare diseases is a really exciting and a huge benefit to get that early access a lot of times, as you mentioned, first in the world. But we've also seen examples overseas where patients are waiting, and with serious illnesses and fatal illnesses have seen declines in health that may be irreversible, and maybe even deaths that could have been avoided with better earlier access. So when you're considering MFN style pricing policies, what lessons can policymakers, or what should they know about those experiences from people who are still waiting for access or experience delays from those countries that they're, envying their pricing maybe, but need to also be aware of what access looks like and the delays in access and what that means.
Yes, we have several examples. Some oncology and rare disease therapies launched in the U.S. are still unavailable years later in countries that rely on quality-based cost controls. In the UK and Canada, patients with rare cancers and genetic disorders often wait years after an FDA approval before gaining access to the same therapies due to lengthy cost-effective reviews and price negotiations. Um, relative to coverage denials based on cost. There are countries that use quality thresholds, and many of these breakthrough treatments are simply not covered at all, regardless of clinical effectiveness, because they don't meet cost effectiveness cutoffs. So people have to understand those nuances. It's as you dig into this, they become quite apparent. And patients are left with the impossible choice of either paying out of pocket or going without life-saving care. And the preponderance will be going without life-saving care because the impact of a rare disease financially on an individual and their family is most often devastating. So, the equity gaps can widen, and we're concerned about that for lawmakers to understand that we don't want to deal with we don't want to engage or have brought upon us what we see in foreign rationing that has existed. Um, we want to protect against discrimination and access to these therapies, and make sure that we're focused on any reforms to improve our current situation with those that are patient centered. And affordability and access should be balanced through approaches like value-based agreements and other forms of innovative incentives, not, kind of simple but potentially even blunt tools that may work in a different context that may not work as intended here in the United States.
Let's talk a little bit more about that. There sound like there are ways to address affordability and through coverage and new and innovative arrangements that maybe match the innovation that is going on with the treatments. We need to innovate our coverage policies as well. And you talked about those value-based agreements, but I was curious about what are some of those alternative approaches that would address affordability issues and coverages and access issues, but still protect timely access to new treatments and can encourage continued innovation. Because it really is a balancing act, I know.
It is, and I think it's a balancing act, and it's especially important given that we're talking about rare diseases and small patient populations and the complexity of these conditions. M More than half of them affect children, and um, more than two-thirds of those children won't live to the age of 5. So the unmet medical need is significant. The impact on these children's lives and their families are significant, and the impact and cost in caring for them, um, as in caring for them symptomatically over a long period of time as their bodies fail them, is very costly, both in terms of medical services, emotional and financial toll on the families and this and society as a whole. So we have to look at that plus the complexity of our healthcare system and understand that this delicate balance is a real challenge. If there was one simple solution, we would have figured it out already. Um, but I think we should be exploring things, kind of run the gamut to understand the pros and cons and their implications of implementing these things, such as, caps on out-of-pocket costs, um, focusing on various forms of targeted financial relief. Um, um, there are things that we've worked on in the past that have been tested, such as scale outcome-based managed entry agreements and annuity style payments for these one-time high-cost therapies, spreading payments over the years and tying full payment to some demonstrated outcomes. Um, it would be good to get, federal support of such pilots and, clear guidance to reduce what is often seen as, legal or regulatory barriers to implementing these kinds of models. But there are great ideas out there that we encourage folks to explore. Um, this idea of pay for success, for example, is a great way to summarize it, and spreading the costs and pay when the treatments work so patients get access and innovators in this space, are, rewarded. Um, we can strengthen the value-based, patient-centered value assessment frameworks that really kind of reject that quality style discrimination that we were talking about earlier. That is something to consider because it protects um, equity and coverage decisions while still allowing for, kind of a systemic assessment of evidence um, and the impact on budget. Um, they have to reflect patient experience and severity, which NORD has, talked a lot about and engaged a lot with lawmakers and regulators on that, and not penalize lives because of somebody's disability or the rarity of their condition.